All right, Jessica.
Hi, everybody. I'm Jessica with BCID.
And I am Jose Hernandez with United Spinal Association. Today we have with us two very intelligent women that are going to give us a presentation on the new Medicaid cuts that are being implemented as we speak. They were delayed because of COVID, but we're trying to raise awareness and push those things back and hopefully get them eliminated. First, want to introduce Nina and allow you to say a little bit about yourself, followed by Kendra.
Wait a minute.
Oh, hold on. Yep. Sorry.
Bro,
I jumped the gun. Go ahead.
So if anybody has any questions, you are only in listen only mode, so you can't speak and we can't see you. But you can go ahead, if you have a question, you can go ahead and put it in the Q&A section that's down at the bottom, or the chat. You can ask throughout and we'll answer them as we go along or at the end. We're kind of just casual about it.
We're also using Otter AI, which is a closed captioning system. So this is something that we're going to have to get used to as well. As you speak, please announce your name. It helps the system identify who's speaking. So I'm Jose Hernandez. I was the one that's speaking, and I am going to hand it off to Nina.
Thank you, Jose. Hi, everybody. My name is Nina Bakoyiannis. I am one of the co-coordinators of Downstate NY ADAPT. A lot of the work that I do at ADAPT is the stuff that we will be talking about today. Outside of my advocacy life, I'm studying to be a psychologist, and I'm particularly interested in the intersection of ableism and mental health, and lately the impact of government austerity measures on our mental health. And I'm also a consumer of CDPA, so these issues hit very close to home.
Good afternoon, everyone. My name is Kendra Scalia. I am a member of Downstate NY ADAPT, and I am also disabled. I use the CDPA, Consumer Directed Personal Assistance Program, as well. In my personal life, I am a trained healthcare policy analyst, and I work primarily in Medicaid and Medicare services.
So those of you who need ASL interpreter, you can click on Brendan's window, click on the three dots, and you can pin him to your screen. So thank you very much, Brendan, for joining us. Nina, we're going to hand it off back to you so that you can start us off.
All right, thank you, everybody. So let me share my screen. All right, so welcome to our presentation today. First of all, we just want to give a big thank you to BCID and US Spinal for having us here today. We're very excited to be here and to be able to foster these really important discussions. So Kendra and I are here from Downstate NY ADAPT to go over the changes being implemented to home care services in New York and how to get involved in advocacy about these issues. So our agenda for the hour, after introductions, we're going to go over the changes that are being made to home care, the processes for how these changes get implemented, both from New York State Health Budget and the Department of Health. We're going to talk about calls to action and our best tips for advocacy, and leave some space at the end to open up for a Q&A. And as a part of Downstate NY ADAPT's summer webinar series, I gave talks on some of the issues we're going to talk about today, but it was specifically in relation to submitting feedback to the Department of Health. And at this point, we are far past that. So if you were at those presentations, we'll be summarizing that and then talking about next steps, both from our organization, but also what we recommend for all of you to do next as well, because this stretches far beyond the Department of Health in a lot of ways. So a little bit about ADAPT. We are a small chapter of a larger national grassroots disability rights organization. Our chapter encompasses New York City, Long Island, and various counties up near Westchester. And one of the main things we fight at ADAPT is against institutionalization of the disabled. And ADAPT has been around for 40 years because it still speaks to a need, because that fight never stops. And as Kendra and I go over the presentation today, I think that'll become abundantly clear. So you can check out both National ADAPT and our chapter on the websites on the screen. That is www.nationaladapt.org or dnyadapt.com. So today we're going to be discussing both personal care services and consumer-directed personal assistance, or what we call CDPA. So we're talking about the traditional home care agency model, where you're under a certain agency, like visiting nurse service per se, and they send you home health aides that work for their company. But we're also talking about CDPA. That's consumer-directed model. It came out of the independent living movement and is designed to give us more autonomy and more say in our care. So we pick our own personal care assistants or PCAs. We have them sign up with a billing agency called a fiscal intermediary, and we're responsible for directing our own care and allocating hours throughout the week. And these services are only available through Medicaid. So to be enrolled, there's a very specific set of rules you must follow. Typically, you must be on Social Security, so there are strict income and asset restrictions, and therefore it's difficult to get married or hold a job. It is possible, but there are many loopholes and hoops to run through. Your hours and your care are essentially determined by the state. You're typically fighting a bunch of bureaucracy to get there, and the reason that I bring this up right now is because I want to make it clear that what we're going to talk about today and what we're fighting for today is one tiny, tiny seed of an issue that is a part of a much larger system that is built against us. And when we put one fire out, there are 8 others and 6 more coming along next week. So I hope everyone here today would be interested in keeping in touch with ADAPT if you're not already. So with that being said, I'm going to pass this along to Kendra, who will get us started.
Thank you, Nina. Before we get into the bulk of our presentation today, we want to make sure that we're all starting off with the same understanding of who does what in New York State and how those processes work. So the US government is structured between 3 branches: the executive, which includes the president at the federal level, the legislative, which includes the 2 branches of Congress at the federal level, and the judicial branch, which is the Supreme Court. On the state level, it looks very similar, and we're going to focus on the executive branch and the legislative branch and how they work together at the state level here in New York. So Governor Cuomo is the top official of the executive branch, and under him is his administration, including different state departments and agencies, which includes the Department of Health. You may see this agency often referred to as NYS DOH, that's New York State Department of Health, or just DOH. The executive branch enforces the state laws, which are also called statute, by issuing regulations. And regulations are essentially detailed rules about a law. The New York legislature contains 2 branches, the state senate and the assembly, and the legislators are the people who were elected to work in the legislature. So your state senator and your local assembly member are legislators, and they're the ones tasked to write state laws. Again, those can also be called statute. And when a potential law is being discussed and negotiated on, it's called a bill. Next slide. We want to also go through the rulemaking process here in New York State, and specifically how portions of the budget get turned into regulations to change the social service programs. So here in New York State, the governor drafts a budget to send to the legislature. Cuomo and his staff, as well as key legislators, hold the decision-making power in negotiating changes to that budget. So typically in mid-January, the governor will submit his executive budget to the legislature, and through the fiscal committees, which are the Senate Finance Committee and the Assembly Ways and Means Committee, the legislator will analyze the budget. They can hold public hearings on major programs or ask for further information from the Division of Budget or other state agencies. Legislature is also required to use a conference committee process between the 2 houses. So that means that the Assembly and the State Senate organize together to deliberate, set priorities, and reach an agreement on the budget. Once a budget is passed, typically this happens around April 1st or before April 1st, the appropriate state agency will write proposed regulations for any of the changes to a program that they oversee. Medicaid changes, home care changes, those things are dealt with the Department of Health. So once DOH releases the proposed regulations, a public comment period begins. Under the first round of public comment, we the people, organizations that represent us, pretty much anyone, has time to have a say in what those regulations read, and they send written comments to DOH about the rules that they want to use. The amount of time can vary, but typically public comment can't be any less than 45 days. And in some cases, in many cases, they'll offer up to 60 days for public comments. So the DOH cannot take any action until those public comments have been reviewed and the regulations are put into place. After comments are received, the department will modify the regulation potentially, and for any substantial changes, they'll issue a second public comment period that will last at least 30 days. After this point, the final regulation will be adopted and will be published. So I know that was a lot of wonky policy talk, but I think it was necessary for us to move forward with today's presentation. And now that we all have a basic understanding of who does what in New York State, we're going to look at what the changes were this year in the budget. Not all of the changes in the budget were bad news for consumers. So here is some of the wins that we got. Assessments for CDPA will now be conducted just once per year, whereas previously they've been conducted every 6 months. Your personal assistant, your PA, can drive you to your medical appointments. Prior to this change, it was only permitted that PAs drive a consumer for errands or social outings, even though some people were using their PA to drive them. Medicaid paratransit will still be available for you to go to a doctor if that's needed, if your PA doesn't drive you or can't for any reason. But you do need to be aware about duplicating billing under Medicaid. So that means if your doctor's appointment requires you to have assistance during the appointment and the assistance is provided by the clinic, you should not also have your PA on the clock during your appointment. If the clinic does not provide that assistance, you can have your PA help you and they can get paid for that help. Another big win is in terms of designated representatives or DRs. These are the people that assume the consumer responsibilities in CDPA on behalf of a consumer that does not want to or cannot complete consumer tasks alone. So DRs now must be present for all assessments and meetings so that they can stay in the loop, ensure they're completing their responsibilities, and provide full information to the assessor. This was an added layer of protection for consumers who don't do the advertising, hiring, scheduling, training, or supervising by themselves. So moving on, we're looking at other changes to the budget that weren't necessarily in our favor. First, the budget cut $45 million from a fund called Workforce Recruitment and Retention. In a traditional agency home care model, these funds are used to recruit and hire home care workers. It can provide bonuses and other benefits that encourage workers to stay long-term. In CDPA, however, these funds are directly used to increase wages because in CDPA, recruitment and retention is the consumer's responsibility. They don't get these funds directly. So this cut actually translated into a base wage decrease of more than $2 per hour in May of this year for some CDPA workers, and it was especially felt in the Hudson Valley area. The budget also created what is called a Medicaid look-back period. The final bill agreed to a 30-month look-back period, which is 2.5 years. And this means that for new Medicaid applicants, the state will look at your financial records and go back up to 2.5 years before you applied for Medicaid. The look-back periods are phased in slowly. So when the change happens, which could be in January 2021 or later, the look back will start at just looking at 3 months previously. Each month thereafter, the look back will add an extra month to how far back they're going to go. So transfers of funds or assets that were made before October 1st of this year will not have any penalty. However, new Medicaid applicants must show their records of all financial assets for both themselves as well as any spouse during that phased-in schedule that I just mentioned. So if there are transfers of assets during the look-back period that are not exempt transfers, the individual is going to be denied Medicaid coverage for long-term care for a certain amount of time. And that amount of time is based on how much money or value of assets was transferred in a non-exempt manner. Wage parity also saw changes in the budget this year. Wage parity just simply establishes a minimum wage and other benefits for all home care workers in New York State. And the budget change requires that all benefits must accrue and be owed directly to workers. So for example, if a fiscal intermediary or agency has any sort of benefit refund, dividends, or profits from that benefit, that must all go to the PA. The fiscal intermediary or agency are not permitted to keep that for themselves. Also included in this wage parity compliance law was that fiscal intermediaries must have an independent audit certifying that their wage parity plan meets the requirements. And finally, the state budget officially declared electronic visit verification, or EVV, in New York to be a provider choice model. That means that each agency or FI get to choose the type of EVV they're going to use. The budget also made changes that will directly impact personal care services and CDPA. So the definition of a PA has slightly changed, and it will now require each personal assistant to establish an individual unique identifier from the state before they can work. We're still unsure exactly what that process will look like, or if that unique identifier stays with the PA if they choose to work at a different FI. Providing information about CDPA services has also changed. So budget language states that all individuals have the right to apply for CDPA no less than annually. It could mean that perhaps they'll only have one opportunity per year to switch from personal care to CDPA, similar to how you can only switch your plan once per year. But again, it's still unclear exactly how these requirements are going to be put into play. An independent clinician panel was also created. This means that the state will be moving away from managed care plans, or HRA, or your local Department of Social Services, whichever you use. They're going to move away from them completing eligibility assessments and annual assessments. Nina's going to speak some more about how this is being proposed to operate, and specifically how the state is proposing to also move away from your personal doctor or GP from completing the annual physician's order form each year. We also saw enhanced utilization review process put into the budget. This allows the Department of Health to adopt standards for an additional assessment of consumers whose need is 12 or more hours per day of care. So the frequency, the type of assessment, who's going to complete it, what it includes, that's all still unknown. It's supposed to be an individual check to ensure that people with high level of need are safe in their communities. And what we need to be aware of is mindful that these utilization reviews do not force consumers out of home care programs of their choice and do not push them into institutional placement. And lastly, a uniform tasking tool will be implemented. This simply means that the state will create a tool or a formula or algorithm for the managed care plan, again, HRA or LDSS, if that's what you're using, that will take the written assessment and turn it into a number representing the total hours of care needed. Next slide. Lastly, and what ADAPT has spent most of our time looking into further, are the changes to eligibility requirements for personal care services and CDPA. So we have two big changes that happened. Now, if you're already receiving these services, this won't impact you unless you lose coverage for some reason. Remember, if you're admitted to institutional placement for 3 months or more, that includes skilled nursing facilities. Usually this happens after a hospital stay. Your MLTC has the option to remove you from their services. And in those cases, these rules will apply when you resubmit an application. So first, individuals applying will need to prove a level of need with at least limited assistance with physical maneuvering with more than 2 activities of daily living. And second, for people with a diagnosis of dementia or Alzheimer's, they'll need to prove that they need at least supervision with more than 1 ADL. The effective date was scheduled to be October 1st, but it most likely won't go into effect until after March 31st of 2021, potentially even further than then, due to the extension of the maintenance of effort, a federal requirement under COVID. And now I'll turn it over to Nina to talk more in depth about the regulations to what this law looks like.
Okay, this is Jose speaking. That's what I wanted to find out. I know that these changes are the ones that are going to be implemented, and how is that going to change now? Like, they're going to go into that Jessica limited assistance, and what are the changes to its current model? So Nina, sorry.
No, thank you, Jose. Yeah, it's, there's a lot up in the air, and kind of the timeline on it is a bit confusing because of COVID. All right, so thank you, Jose and Kendra. I'm gonna talk about what power the Department of Health has in these situations. Because essentially, like Kendra said, they have the power to interpret and decide how to implement whatever law is given to them by writing rules about that law. So first, I want to talk about the new eligibility criteria that Kendra talked about and what the Department of Health can do with that. But before I get into the weeds on that, I want to give context to a couple things. So the DOH has been less than forthcoming about certain things, but it is pretty well accepted in advocacy circles that they are going to use something called the Uniform Assessment System, or the UAS, in their regulations. The UAS is a 2-hour interview that the nurse from the state completes in your home during the yearly assessment process. And it encompasses a list of different activities of daily living, ADLs. And the nurse picks from a drop-down menu how much help you need for each ADL. And it encompasses these 7 different options that I have on the screen here. So let's say, for example, there's bathing, and they ask you how much help you need with bathing, and then the nurse picks independent, setup help only, supervision, limited assistance, extensive assistance, maximal assistance, or total dependence, right? So according to the new eligibility criteria, following the UAS, you would need limited assistance with physical maneuvering, which is basically number 4 on the UAS. So if you need assistance with setup, right, putting the item within reach, handing you the toothbrush, if you need oversight or queuing, and you don't have a dementia diagnosis, that ADL, even if you need help with it, will not count unless it is physically maneuvering your body. And for people with dementia or Alzheimer's, you need to hit number 2 on that list, right? So when the nurse does this assessment, they click all the things, and then you get a score from 1 to 18 that says how much care you need, right? Which I'm going to get into later. But the point is that this is in very stark contrast to what the eligibility criteria had been, which was just needing any kind of assistance defined broadly with at least one personal care service. Furthermore, the Department of Health has the power to define the activities of daily living that the law now kind of defines or puts in. And it looks like the DOH is planning on using the ADLs from the UAS, which are just these 7. So bathing, hygiene, dressing, walking, locomotion, transferring on and off the toilet, toilet use, eating, and bed moving, which means turning in bed, right? So incredibly restrictive. And to put this in a little bit more context, New York State clarifies between level 1 and level 2 care. Level 1 care are instrumental ADLs or IADLs, how we interact with our environment, tasks like showering, cooking, laundry, whereas level 2 care is more body-focused tasks like showering, dressing. So not only are they planning on not including any IADLs, but only these very short list of 7 ADLs that doesn't include transferring in and out of wheelchairs and a lot of other really, really important things. So again, in stark contrast, the current criteria includes both IADLs and ADLs and a list of over 20 tasks you can choose from. And this is what they want to change it to. So we're quite literally watching the government subscribe to the medical model of disability, which is quite scary. The UAS was never designed to be an eligibility assessment. It is not comprehensive and it is not nuanced. Next, I want to talk about the new yearly assessment process. So everyone on home care in New York State knows that we have to get recertified every year or every 6 months as if something is magically supposed to happen. And the biggest change is that we will no longer be able to be assessed by our own doctors. It must be through a Maximus provider. So doctors or assessors that the government has pre-approved that don't know us, that we're not familiar with. Typically every year we get our paperwork filled out at our yearly physical, right? But now we have to set an entirely separate doctor's appointment for recertification. So what they're proposing is that the process will go something like this. So you have an independent social or environmental assessment. A Maximus provider will complete the UAS at your home. That information gets sent to a Maximus doctor. They're allowed to contact our personal doctors and see our medical records, but they're not supposed to really be our doctors. And this is another concerning part, is that if you have more than 12 hours of care, a panel of independent assessors has to hold a meeting to see if the current plan is appropriate. After that, your human resources or social service case managers will get the plan of care, modify it, determine your hours of care, which I'm going to get back to in the next slide, and then do another safety assessment to see if we're safe in the community or if we can be more appropriately served with other services. So there's a lot more emphasis on checking that we're safe in the community, which is concerning. That can be skewed in a way that I think we should keep in mind. So how they will determine hours of care. As Kendra said earlier, they're creating a uniform tasking tool to help determine our hours of care, right? And typically the nurse uses their clinical judgment to determine how many hours of care we receive. Yet now it sounds like the DOH is planning on using a modified version of the UAS to produce an algorithm that will determine how much care we deserve every week. So it will all be up to that score that the UAS produces, the drop-down menus. We have to make sure the nurse clicks the correct thing, and a computer algorithm will decide this for us, which is also very scary, because how much humanity are we going to be removed from these processes? So this is a ton of information to take in and digest. So I hope that people jot down notes or questions. We can hopefully get to them at the end. And we also really want to focus on what we can do as activists in the community. So the DOH was taking public comments until September 14th. The webinars that I gave over the summer were about that. You can check out our website to see what we essentially ended up sending. So at dnyadapt.com in the blog section, we post various press releases. But in summary, some of the main points that we hit was emphasizing how much these regulations set up an environment where those that are not disabled enough don't get services, and those that are too disabled have to go through these more lengthy assessments where it becomes easier for the state to judge them as more fit for an institution, right? So we had a few main points: that they should expand the ADL list to include IADLs, that the UAS is not an eligibility tool, and that they should define physical maneuvering as broadly as they could. And then lastly, they really didn't define disability in a nuanced or realistic way, because an algorithm and an assessment from a doctor that doesn't know us is not going to be a very accurate description of our needs. So since then, our chapter has really expanded efforts to reach out to state government, because they were responsible for passing the physical maneuvering with 3 ADL rule. We've been meeting with various assembly people and senators to explain to them the reality of what will happen if the budget goes into effect. And we asked for their support in writing to the governor to ask him to issue an executive order to repeal this section of the budget, right? Because Cuomo has the power to do this on the grounds of coping with the disaster emergency at hand. So we've written to his team requesting this, specifically due to some of the issues I'm going to outline in the next slide. And we've received interest from some state legislatures about a bill we're proposing that would redact that section of the law. So what we're hoping is that Cuomo can delay implementation until we get that particular bill passed, or until the next round of the health budget when it can be removed. And we're also working on crafting our own long-term bill that would lessen the chance of something like this happen again. We're still working on it, but in summary, we're hoping to create something that will give disabled consumers a lot more say in these processes, so we have a little bit more control over the services that we rely on every day. And there are a few different backbone arguments to our advocacy so far, and we hope that all of you interested can take these with you. And these are much more in depth than the bullet points that I've listed here, but I'm going to kind of go over them briefly. So CFCO is a state plan that New York opted into. It stands for Community First Choice Option. ADAPT was very instrumental in getting this passed in the first place across the state and federal level. It's kind of like a Medicaid expansion pack where we get home care, but we're also supposed to be getting additional services like home modifications and transportation. And because New York opted into this, they receive an additional 6% funding from the federal government. And again, this is a much larger conversation, but for the purposes of right now, there are 2 important things here. Firstly, CFCO mandates that IADLs, instrumental tasks of daily living, must be included, and that there should be no difference in services based on type or severity of disability. So clearly, this new criteria violates that. And we're writing to the governor saying, firstly, if you go through with this, you're risking money. But secondly, Olmstead, right? Because Olmstead is about making sure that home care is the first choice for disabled people. And if we're setting up new criteria that actually makes it easier to get approved for nursing homes over home care, that is in direct violation of Olmstead. And thirdly, COVID is really important point here that we're trying to center. We have seen thousands of disabled people die in institutions from COVID, and changes that make it easier for people to get admitted to them will directly cause the deaths of thousands of more people, especially in the time of COVID. And that brings me to my last point. It is the moral thing to do, right? We're not a functioning society if disabled people are fighting this hard for the right to live. And for society to acknowledge that we get treated not that great, they have to come to terms with the fact that we are human, they are human, and they're no better or different than any of us, and they can join our community at any time. So on that note, Kendra is going to talk you all through the rest of the presentation about ways to get involved. Thanks, everyone.
So now that we've gone over some of the issues with the budget, the impact on CDPA and personal care services, the things that ADAPT has done so far, you're probably wondering, what role do you play? So while the actions of organizations like ADAPT are important, the best advocacy happens when individuals like you share your personal stories and communicate those to others. So that is to say that you play the most important part in making a difference. So here we have just a few different ways to get involved. You can choose 1 or 2 or 3 or all of them. So first, writing a letter to Cuomo. On the New York State ADAPT, the Downstate New York ADAPT website main page, that's dnyadapt.com, you scroll down just a little bit and in the middle you'll see, how can you help us stop Cuomo from changing eligibility criteria in home care? There you're going to find a template letter that you can send to, and other information about the impact of this section of the budget. You can also send an email via Cuomo's website. You can make a phone call or send a letter via fax. If you don't have access to a fax machine, please contact Downstate New York ADAPT and we can help. If you're writing your own letter, the ask is that Cuomo use his powers to issue an executive order to delay or repeal the eligibility changes to Medicaid personal care services and CDPA. You can use the messaging that Nina just went over about our arguments, and it can be really compelling, again, right now especially, to lean in on that COVID-19 impact and our moral obligation as a community to ensure that these changes don't harm seniors and people with disabilities. Next. You can also write an op-ed. So an op-ed is a short article written by a community member that is often in a newspaper page opposite the editor's remark, op-ed. Sometimes it's also referred to as opinions and editorials page. You can write an op-ed to your local newspaper and get it published on pretty much any topic impacting the lives of other community members. Each newspaper has their own guidelines as to how long an op-ed should be, how and where to submit them. So typically op-eds are 600 to 700 words, but they can be shorter. You can Google search how to submit an op-ed to your local newspaper of choice. So op-eds are printed in a physical newspaper or online or both. A good op-ed will be short and to the point. It stays on messaging, does not try to talk about too many problems at once. It will clearly define the problem, briefly tell your personal story and the impact, and close with an ask, right? We always want to put out a call to get the community to act or put pressure on an elected official to do something specific to fix this problem. You want to open your op-ed with a sentence or two to draw readers in. You want to make it personal, be accurate and honest. So if you're not comfortable talking about CFC or any of the other Olmstead or larger policy changes, you don't have to. Use your own voice and a tone that feels comfortable for you. You don't want to appear uninformed, and you also don't want to appear too hostile or aggressive. Remember that the general public usually doesn't know about these issues, and so they're really not apt to support an angry message when they don't understand yet what the problem is. Next slide. Connecting with your legislators is a very powerful advocacy tool. If you can't get to Albany, especially right now, you can take a meeting at your local district office, or you can request a Zoom conference call, just like we're doing today. Remember that your state senator or assembly member may not always be available to meet with you. They may schedule a meeting with a policy director or other staff, and that is completely okay. So don't feel put off if you can't get a direct meeting with the representative. Many times their staff are the people that know more about the topic at hand. They're the ones working behind the scene, doing the research and writing correspondence, and they're the ones that are going to be there ensuring that the representative keeps your issue at the forefront during internal discussions. So during these meetings, of course, always be polite. You want to introduce yourself, use your personal story to explain the problem and the impact, and always end a meeting again with an ask. What do you want the representative to do? Ask for things that are realistic. Ask for things that are within their authority. If possible, when you go to these meetings, be prepared with a one-page handout about your issue and specifically what you're asking for. If you're having a meeting online through Zoom, it's okay to ask for their email address and to follow up with your materials after the meeting. While we always start talking amongst ourselves in the disability community about what's happening, we need to be alert that other groups must also get involved in order for these conversations to grow. So this includes talking honestly to family, friends, including your personal assistant or home care worker, and your acquaintances. So you can discuss your personal experience. You can talk about how the changes might in fact impact you and others in the disability community. And you can frame your conversation in two ways. First, lack of access to basic health care for disabled people is really not a functioning society, right? And second, that being non-disabled is almost always a temporary status. So someone can become disabled and may need to rely on these same set of services at any time in their life. You want to ask them to do something to help you. So sign a petition, write a letter, make a phone call, something that doesn't require a lot of time or expertise, but can really demonstrate the power of more people being involved supporting the subject. And remember, the most effective advocacy happens through coordinated efforts. That means that the message you send should be similar to the messaging of other individuals and other groups. So if 10 people write their own letters to the governor or legislators, and they each include a different ask, they won't be very successful. So we need to be sure that what we're asking for won't create problems down the road for other groups of other disabled people. And to help us to get from where we are today to where we need to be next year, we all must connect with ally organizations that support our issues, such as Medicaid Matters, CDPAP, NILE, and others. Ask them what they're doing about these budget changes. You can share your ideas on what can be done to try to change it. And one of the most important things is you want to listen to them, right? These are our allies. While you will always be the expert on disability and the impact of these changes, these organizations have a lot of expertise in the processes and the legislature. So they're going to have more information about what potentially could be done. We might not have the same ideas to begin with, so don't be discouraged. You want to keep continuing to have these conversations over time and find that common ground. It does exist, I promise you it does. You'll quickly realize that we all have the same goals, but we're probably looking at it with differing ideas about how to get there. So social media is another powerful advocacy tool, and I'm going to explain two platforms to you today, Twitter and Facebook. Next slide. Twitter is a very effective advocacy tool. To use it appropriately, you want to get as many followers as possible to see your messages, called tweets, and to use hashtags. So first, to get followers, you need to follow others. When people choose to follow you, if you like their content, follow them back. You can find people to follow by checking out different hashtags that you like. So hashtags will group tweets together that are writings about similar topics. So when someone searches a specific hashtag, they'll see your tweet and then everyone else's tweet that used that hashtag as well. So it's best to use a hashtag that's already in use because others will be following it. If you can use the search bar in Twitter, this is really the best way to see which hashtags are in use. You want to just begin by typing in the hashtag symbol and then the first few letters of a word. So if you type out DIS, you'll get a full listing of all the hashtags that follow under DIS. So disability, disabled, etc. If it's not your hashtag, be respectful of the intent of the hashtag and just be social etiquette when it comes to hashtag use. When writing out a hashtag that has more than one word, such as hashtag we are essential, you want to capitalize the first letter of each new word to provide access to everyone such that your hashtag will be read out loud by screen readers and is also comfortably legible for others. A good hashtag will drop out of use if it's too complicated or it's misunderstood. Also, don't place any spaces between the words of your hashtag or it breaks the link and people will not be able to find your message. And finally, with Twitter, you want to use the @ symbol followed by a person's username, and that will allow you to tag them directly. So @NYGovCuomo will tag Governor Cuomo's account and he will be able to see any tweet that tags him in it. So your local assembly member, your state senator, other organizations in the community, they most likely all have Twitter. You can search for their handles in the Twitter search bar as well. The more likes and retweets, RT, a tweet gets, the more that tagged person will be notified of the tweet. So that's why it's really important to have a lot of followers and have them retweet your content. On Twitter, the one downside is the character limit of 280 characters. So you really need to be precise. Otherwise, you need to start a thread in order to link multiple tweets together. Next slide. Here you can see we have example tweets to demonstrate how to use tags and hashtags within your message. So for the first one, this message will show for anyone who follows topics on CDPA, Save CDPA, or Disabled, since all three of those are hashtags, and the DOH as well as the governor's account will be able to see this tweet directly, as well as all of the retweets that it gets. Next slide. And finally, we have Facebook. So Facebook is a really good advocacy tool when it comes to building community. First, you want to start by following pages of organizations that support our issues, like CDPAs. Pages are for organizations where they will post information to their members. And you can comment on their posts, but you cannot post your own message directly to that page. To post your own message, you want to join groups. Groups are places where individuals talk about specific topics that they're all interested in. And you can search for groups in the Facebook search bar. There are groups on every topic you can think of. Some of the really great groups to follow for our issues include ADAPT, CDPAP Watch Discussion Group, New Yorkers Against EVV, Living with MD, and My Olmsted Rights Support Group, and many, many, many others. So please feel free to follow whichever groups you're most comfortable in. When you see a post on a page, remember to share it to your personal Facebook page, but also choose share to groups. And you can post that, that message directly into groups that you're a member of. So hundreds or even thousands of people will be able to see it because of a one click that you made. Facebook has privacy settings for groups. So remember that you cannot share information from a group to another group or even from that group to your personal page if the group is set to private. And it's important to stay active in your groups because this is how Facebook algorithm determines what messaging and content they show you on your main timeline. So when you post in a group, stay on topic, be friendly, engage with other people who are posting. And while it's interesting to really see what's happening with Supreme Court nominations, for example, that information is most likely not going to be welcome in a group that's specific to EVV or to something else. So just be aware that you're posting relevant content. With Facebook, the really great thing is that groups are not set in geographical areas. So you can literally connect with other disabled advocates all over the US and even worldwide. It is extremely powerful and a really great tool to be using to build your network. And our last slide. So thank you for having us here today. Nina and I really wanted to thank CDPA's Leading Age, NYLAG, and CDPAP Watch for the wisdom and resources that we've relied on over the past few months. And now we'd like to take any questions that you have for us.
Hello, this is Jose speaking. Thank you. I've learned so much, and we actually have a few questions. Jessica, would you like to start with the ones that you can see, and I'll do the ones that you can't?
Okay. I see James, and he says, in regards to cutting hours of personal care assistance, there is a Second Circuit Court of Appeals decision which held that Medicaid may not cut an individual's hours unless the individual's medical condition has improved. Therefore, how does the current changes affect or counter this decision?
Excellent question. So these changes should not impact that decision. You should not be seeing your hours get cut because of the eligibility changes or any of the budget changes. If you do, please contact ICANN, ICAN.org. They are a really great place, a really great resource that you can go to and get one-on-one assistance. Yeah, you should not be seeing your hours cut from these changes.
I saw one from Gina earlier, but I don't see it now.
Nina answered that one.
Oh, did you? I'm sorry.
Yeah, it was a very good question, actually, if people want to look at it in case anyone
How about I repeat the question?
Yeah.
Gina, what if you need more than minimal assistance? If you need more than more assistance than limited assistance, does that harm or help?
Yeah, it helps. So you need at least limited assistance. So if you need, there were 7 of them. So instead of 4, if you need 5 or 6, which is like maximal dependence, that's fine. That counts. It just can't be less than limited.
And Virginia?
Virginia, yes. Wait, well, Val first said, will the slides be emailed?
Yes, we can make this presentation available. We will send this off to Jessica and Jose after the meeting, and they can send it out to all registered attendees.
Okay, and Virginia says, what about the treating physician doctrine of Social Security disability evaluation?
So when it comes to that, really, it's more about that the physician needs to disclose different treatment options that are available. And where that becomes challenging is that the majority of local community GPs are unaware of certain home care programs, especially consumer-directed personal assistance. So this is not going to have any change to what your personal physician can say to you or offer to you in terms of treatment. But what it will do is if you're applying at the point of the Medicaid department, they're no longer going to be providing that list of you're qualified or eligible for this program, this program, this program. And they're just going to generally give you an overview of you can get home care, and you're going to have to figure out on your own what those different types of it look like.
And we have 2 questions that were emailed in. One of them is from Joel Hortenstein. My son is in an IRA. Will the Medicaid cuts affect his home group home?
I'm sorry, I'm not really positive about that answer. I'm going to lean towards no. But I do recommend that you contact your group home administration and see if they can give you more information.
And we have one more question that was emailed to me. How will this affect people on waiver programs?
So yeah, it will affect people on waiver programs as well. So if you're on a waiver program and you're seeking home care services, CDPA, self-direction, these eligibility changes are also going to come into play for you.
Yeah, and sorry.
Go ahead.
I wanted to clarify too that this should affect people applying in. So theoretically, everyone currently enrolled, we already passed eligibility criteria, so we should theoretically be fine, right? But of course, there are always glitches in the system. If something happens, you get kicked off or whatever, that's not unheard of, right? But yeah, I'm also on a waiver program too. So it affects all of us, unfortunately.
And we have Trina that has her hand up.
I had a question. Attendee. Are there any updates regarding the CDPA RFO? When can we expect decisions to be made regarding this issue?
So the CDPAP RFO, the request for offers, which was a process that the state entered into to get all of the fiscal intermediaries to essentially contract with the state in order to operate. We're still waiting, and there's been no update. So unfortunately, I can't give you any more information than maybe it'll come soon.
So I'm going to allow Trina to talk. She also says that waiver folks are exempt from the look back as well. So Trina.
Hi, I'm Trina. I'm in Brooklyn. I just have a couple of comments. One about the CDPAP RFO, the FI RFO. DOH's website actually says it's awaiting the New York State Comptroller's approval. So, so I guess there's 2 different agencies now kind of involved in that. So we might want to keep checking that website every now and then. But yeah, it's waiting on the New York State Comptroller's approval for the contracts is what I know. With the IRA, it's yes, it is Medicaid funding, but it's through the OPWDD system. And there have been some organizations in New York State, advocacy organizations, disability advocacy organizations that have really been following that closely. From what I understand, the IRA reimbursement issues have been kind of dealt with in the OPWDD system. I'm not saying it's fully resolved, but I just know that that's more of an OPWDD system issue. I know that with COVID, there were some 20% cuts being proposed. Quite frankly, I haven't been following that, but that should be in the OPWDD channels with reimbursement issues with that. Kendra mentioned ICANN for MLTC issues, hours being cut and things. For folks that are in managed long-term care, that's a great source. It's been my experience as a board certified patient advocate, however, that if folks are not in a managed long-term care plan, but are just in MCO, meaning managed care organization, then the proper channel for that, and you'll be directed to that by ICANN, would be the Community Health Advocates program. And that's a division of CSS. Community Health Advocates. They're open till 4 p.m. Monday through Friday. They don't list 4 p.m. on their current website, so just be aware if you're calling between 4 and 5, you're not going to reach them. NYLAG is an awesome source for a lot of us advocates in New York State. Their current website does say that the look back has been delayed actually until April 1st, 2021. I don't see the primary source for that, except it's mentioned multiple times on their health assets advocacy page. I can put that link in the chat for those of us that are policy oriented and policy wonky. But yes, I guess it's coming down the pike, that information, but we don't have a primary source. Last thing I just want to mention, I just found that there was a state plan amendment submitted to CMS. I just found this like 10 minutes ago. There's a state plan amendment submitted to CMS on the personal care and CDPAP eligibility changes. I will share this with you. It's called a SPA. It's called a state plan amendment. Actually, I think I might have just shared that with the panelists, but I'm having a little technical difficulties. But
we can share it with everyone.
Okay. This is part of the process of New York State changing the Medicaid state plan. It gets submitted to the federal government, then it's reviewed at the federal government. Sometimes these SPAs, okay, state plan amendment, SPA, kind of sit on CMS's desk for a while, months, sometimes years. So we don't know if it's going to be approved or not. But there's a lot of good information if you familiarize yourself with these SPAs and you know, because the way New York State works, it's, I call it like the Medicaid Bible of New York State. It's really like the plan, the New York State Medicaid plan. It's about 1,000 pages, if not more. And each of those pages, anytime the state makes any kind of changes to its Medicaid state plan authority Bible, it has to submit it to the federal government and wait for it to get approved. Not every kind of change, but most. So that's, yeah, that's all I wanted to add.
Thank you, Trina. Yeah, Trina is another ADAPT member, a source of wealth in the policy areas. So thank you for that. I see another question about EVV. Are we responsible for picking our own EVV system? If so, when do we need to make that decision by? So when it comes to electronic visit verification, if you were here last week, I gave a presentation all about EVV and the implementation here in New York State. And what it comes down to is that your fiscal intermediary or home care agency must pick that EVV system. And there is a process, the stakeholder engagement process, that consumers and personal assistants, home care workers should be involved in so that you're all communicating together. EVV will be required to be used in all personal care services on January 1st, 2021. So if you're not already using an EVV system, you will be using it very, very soon. As far as I know, everyone's on schedule to go forward with the January 1st deadline.
All right, if there aren't any other questions, I would like to thank Nina and Kendra for joining us. And more importantly, I want to challenge all of the attendees that are here. I'm going to put into the chat a bunch of information. If you have any additional questions and would like to find out more information, you can always email me or Jessica at the emails in the links, and sign up to be one of our members with ADAPT, sign up with NYC Spinal, so you could keep up to date with our presentations, and you can gain access to our free publication, the New Mobility Magazine. But more importantly, the national organization, United Spinal, is doing a district mobilization map. So if you wanted to add your voice to the Congressional District Mobilization Map, sign up. And when there are issues that are on the federal level, we can reach out to you guys and say, hey, we need your voice to be added to that conversation. So thank you. Thank you, Brandon, Jessica, Kendra, Nina, everyone in attendance. I'm going to leave this up for a few minutes while everybody says their goodbyes, and you guys can copy and paste that.
All right, thank you. Thank you, Jose and Jessica. Thank you for all our attendees. It was really a pleasure to be here with Nina today.
Thank you, everyone. I'm so glad to have these conversations. I put in the chat, if you're interested in joining ADAPT, if you're not already, or getting on our email list, you can head to dnyadapt.com and sign up. So thank you for having us today.
These girls are amazing. You know, you want to join up. We are a part of the Medicaid and CDPAP group. Kendra is there. We're all on there. We're all trying to make a difference, and we need all our voices that we can get.
Very well said.
Thank you.
Thanks, guys.
Bye, everybody.